The most important message for colon cancer is that we believe it's almost a preventable illness. If patients are adequately screened by good endoscopists underneath the correct time, we can probably cure the majority of cancers by removing the polyps before they become cancer. And I think that's the big push that we need to have right now. There's been a large increase in colon cancer in what we call younger patients, which would be patients under 50, right? In fact, it's been a large enough increase that we changed the screening recommendations now to 45 from 50. But now that people are starting to become attuned to that risk or that possibility, I think they're starting to screen them more quickly. When they do the colonoscopy and they see a polyp, there are times that they can take that polyp out, and if there's a small focus of cancer in that polyp, but the margins are clear, those patients may not need more surgery. It depends on a couple factors and on the specific cancer. And each patient's treated individually. We look at those polyps and those cancers individually and try and get a treatment plan that will fit them, so we don't do any unnecessary surgery. And there are patients that we can avoid surgery on and just follow them more closely. Radiation for colon cancer is only used for rectal cancer. And generally we use that before surgery. And the reason that we use it before surgery is it will decrease the size of the tumor, and which will improve our odds of removing it completely, probably improve our odds of being able to put them back together so they don't have a colostomy bag, and it definitely decreases the long-term recurrence rate, so it improves survival. Chemotherapy is generally based on the lymph nodes. When we take out the tumor and the lymph nodes, if the lymph nodes are all negative, we generally do not give chemotherapy. In rare instances we will, but we generally don't. If the lymph nodes are positive, that means that the cancer has gotten through the wall of the colon and is trying to become more systemic, and that's when we would use chemotherapy. The chemotherapy that we use today for colon cancer is very effective, and the side effects are very well tolerated. Our options for treating what would be considered terminal colon cancer or stage 4 colon cancer have expanded, and our survival has expanded as well. Now we treat it almost like a chronic illness. One of the great things at Riverside is that we have a whole team of people working. And so that includes the gastroenterologist, the surgeon, the medical and radiation oncologist, and the radiologist. And I think it's a better way to approach these kinds of cancers because it allows a greater breadth of knowledge. If you have colonoscopies as recommended, so at the recommended times, right? These starting at age 45, every 10 years if it's normal, or sooner if they find polyps, then we expect to find polyps that are smaller, and the chances are that if a cancer had developed in a polyp, it'll be earlier. And statistically, it's shown that your chance of dying of colon cancer is less if you have good colonoscopies done by a good endoscopist. And at Riverside, our endoscopists are well above the national average for finding polyps, which is a key marker as to their quality.